brings a world of possibilities, and we are eager to explore them with you. An auspicious good evening to all the presented dignitaries and delegates. I'm Sanofu, your host for this delighted launch event. Advancements in the field of medicine have always been a testament to human determination, creativity,
And a warm welcome to everyone present here for the inaugural CME on laser coronary angioplasty. First and foremost, I extend a special welcome to our Joint Managing Trustee, Thiru R. Sundar. Sir, your guidance and unwavering support have been instrumental in organizing such CME programs. We are honored to have you with us today. I also welcome our guest speaker, Dr. Anuj Bashin from Icon Hospital, Mumbai, and Dr. J.K. Periyasamy, our senior-most cardiologist. A warm welcome is also extended to our CEO, Sri C.V. Ramkumar, Dr. S. Alagappan, Medical Superintendent, and all the senior cardiologists and cardiothoracic surgeons attached to Sri Ramakrishna Hospital. I welcome and thank all the special invitees, doctors, and their family members for accepting our invitation and gracing this occasion. Without your active participation, arranging this academic program would not have been possible. As we know, cardiovascular disease remains a leading cause of morbidity and mortality worldwide. In response to this challenge, continuous research and development in interventional cardiology have produced more effective and less invasive treatment options. Among these, laser coronary angioplasty stands out as a groundbreaking technique that offers new hope to patients with complex coronary artery disease. During today's meeting, we will hear from leading experts in the field who will share their insights on the latest clinical data, procedural techniques, and patient management strategies. We will also have the opportunity to discuss the patient practical applications of laser technology in coronary intervention and how it can be integrated into routine clinical practice. I encourage each of you to actively participate in the discussions, ask questions, and share your experiences. Your contributions are invaluable in advancing the adoption of this transformative technology. Thank you for being here and for your commitment to advancing cardiovascular health. Together we can make significant difference in the lives of our patients. Enjoy the meeting and let us look forward to a day of fruitful discussions and new learning.
SNR Sons Charitable Trust, Sri R. Sundar Sir, to present the floral bunch to our beloved guest speaker, Dr. Anuj Basin, Director, Department of Cardiology, Icon Hospital, Mumbai. Thank you, sir. Prioritizing the event to make this a special start, I cordially invite all our respected dignitaries on stage for the launch of Form Board with a great round of applause. That was a delightful scenic presentation. Thank you everyone, and I request all to take your seats. Without any further ado, let me request our Joint Managing Trustee, SNR Sons Charitable Trust, Sri R. Sundar Sir, for the inaugural address.
Respected Chairperson of the Day, Dr. J.K. Periyasamy, distinguished guest speaker, Dr. Anuj Basin, Icon Hospitals, Mumbai, Dr. S. Rajagopal, Medical Director, Sri Ramakrishna Hospitals, Dr. S. Manoharan, Consultant Cardiologist and HOD, Sri Ramakrishna Hospitals, Dr. S. Balaji, Consultant Cardiologist, Sri Ramakrishna Hospital, Dr. T.R. Nandakumar, Dr. Vikram Vignesh, Dr. G. Tyagarajan, Dr. Madheshwaran, our CEO, Thiru C.V. Ramkumar, Medical Superintendent, Dr. S. Alagappan, other consultants of Sri Ramakrishna Hospital, and most valued members of the medical fraternity from the Department of Cardiology, and dear participants, a good evening and a warm welcome to this inaugural CME on laser coronary angioplasty. Sri Ramakrishna Hospitals has always been at the forefront of adapting cutting-edge medical technologies to enhance patient care, and it was established in the year 1975 by SNRN's Charitable Trust. Our hospital has grown from a modest healthcare facility into a premier institution. Comprehensive medical services across various specialties. Over the decades, we have remained committed to our founding principles and delivering high-quality, affordable healthcare to the community. Our mission is to bring the best of medical sciences to the people of Coimbatore and beyond. And today's event is a testament to that commitment. Our hospital has always been a pioneer in adapting to the state-of-the-art technologies and to provide the best possible care to our patients. And our cardiology department is equipped with the latest diagnostic and therapeutic equipments. And our team of highly skilled cardiologists and cardiac surgeons are dedicated to delivering exceptional care. The introduction of laser coronary angioplasty is yet another milestone in our journey towards excellence in cardiac care. As we focus on the importance of heart health, it is imperative to acknowledge the rising prevalence of cardiovascular diseases. Coronary angioplasty represents a significant development in our ability to treat complex coronary and artery dysfunctions. This CME is particularly noteworthy as it brings together some of the finest minds in cardiology. We are privileged to have with us a distinguished panel of guest speakers who will share their insights on various aspects of laser interventions. I would like to take this opportunity to express my gratitude to the organizers of this program for bringing together such an esteemed group of professionals. This program will definitely serve as an invaluable platform for sharing knowledge and expertise, ensuring that we collectively advance in our mission to combat heart disease with most effective tools available. In conclusion, let us take full advantage of this program and take this opportunity to learn, share, and collaborate so that we can continue to provide the highest standard of care to those who trust us with their health. And I would like to take this opportunity to again thank those who are all present here, our doctors and the organizers, and best wishes for the program. Thank you.
Thank you for your...
Good evening, all of you. A warm welcome from the Department of Cardiology and from Sri Ramakrishna Hospital for all the faculty and all the people who come from faraway places. See, I will give you a brief resume of the Cardiology Department of Sri Ramakrishna Hospital in a nutshell. See, it's a tertiary care and multi-specialty hospital in this part of the country. It was started in the year 1975 as pointed out by our beloved Joint Managing Trustee. It was started in the year 1975 and is managed by the SNR Sons Trust. The hospital itself was established in the year 1970 by the most illustrious sons of Dr. S.N. Rangasamy Naidu. From right to left, Mr. Sinnasamy Naidu, Mr. Ramakrishnan, Mr. Ramasamy, the present trustee's father, and Mr. Venkadesulu, our joint managing trustee's grandfather. The Department of Cardiology was started in the year 1991 under the guidance of the then Managing Trustee Sevaratna, late Sri R. Venkateswalu. Facilities like TMT machine and color Doppler machines were introduced for the first time in Coimbatore. Color Doppler was available only in Ramakrishna Hospital at that time. So people used to refer cases from all over Coimbatore to us. And moreover, our managing trustee, that time managing trustee, Mr. R. Venkateswalu, started many departments, not only cardiology, neurology. Dr. Rajagopal will remember, he started all super specialty departments of the hospital. So we started performing closed heart surgeries in the form of mitral valvotomies and PDA ligation and all that. The cath lab and open heart surgery facilities were introduced in the year 1995, and we started performing angioplasties in a good number. Open heart facilities, cardiac facilities were also started at the same time. We started performing many coronary surgeries, pediatric surgeries. Lot of pediatric surgeries were done in our hospital. Actually, those days, pediatric surgery, cardiac surgery was done only in our hospital, not in any other hospital in this part of the country. We have a whole array of non-invasive testing facilities in our hospital. We have about 4 TMT machines and 4 echocardiography machines where you can perform 2D, 3D, transthoracic, transesophageal tissue Doppler, the whole gamut of 2D echocardiography you can do. We have recently acquired intracardiac echocardiography also. And we have facilities for Holter monitoring and ambulatory BP monitoring. See, as science advances, as angioplasty progresses, we understand the difficulties in performing angioplasty. So our hospital performs both simple and complex angioplasties like bifurcation stenting, left main stenting are routinely performed in our hospital. Emergency like primary angioplasty for STEMI, ST elevation MI, acute MI is done 24/7 in our hospital. Both primary and ad hoc, suppose if the patient has received thrombolysis outside, if he needs angio and further angioplasty, that also we do 24/7 in our hospital. Our cath lab is open all the time. In coronary angiography, in coronary interventions, it is becoming more and more relevant that lesion assessment is very important. Lesion assessment of the morphology and as well as the physiology. We have facilities for assessing the lesion in the form of intravascular ultrasound and optical coherence tomography. Both are available in our center. So we can take the help of, we can assess the lesion, whether the patient needs angioplasty, whether you can defer angioplasty, whether you can follow him up on medication. All that can be deciphered from whatever this one is available. This OCT and ultravascular ultrasound is for morphological assessment, that is anatomic assessment. For physiological assessment, we have FFR, IFR, all these are various ways of assessing the lesion. All the facilities are available in our hospital. And you have been seeing the, you have to modify the lesion. Suppose if the lesion is very calcified or highly fibrotic or highly thrombotic, you may need to modify the lesion before you put a stent or before you do anything, any intervention. So we have a lot of gadgets to do this. One is the rotational atherectomy and the other one is orbital. Both we have. And intravascular lithotripsy is also, we have. That is also we are having. The mode of contention of today's discussion is our laser angioplasty. See, these are all cutting edge, really, truly cutting. It is cutting the edge of the calcium of the vessel. And by that, it is allowing our stent to pass through and better stent apposition and stent delivery. That is the only idea of all this. So we have various ways of doing that. One through rotational atherectomy, the other one orbital atherectomy, the third one is intravascular lithotripsy. This is the latest we have added to our armamentarium of all these gadgets. See, medicine is more of science, more of, not of, the art of medicine is what we all practiced. Now it is a science. So you must have all the gadgets to perform all the procedures. And Apart from this, we also perform device closure of ASDs, PDAs, and PDA and VSD. Percutaneous bowl, mitral and mitral aortic and pulmonary angioplasties valvotomies are done in our hospital. In fact, we are the largest performers of mitral valvotomy in this part of the country. We have also performed aortic valve replacements, pulmonary valve replacements in our about 7 or 8, about 10 aortic valve replacements and 1 pulmonary valve replacement we have done. We routinely implant pacemakers, single chamber, dual chamber, ICD, as well as CRT in our labs. All our narrow complex or wide complex tachycardias are managed by RF ablation. Recently, we have acquired another cryoablation procedure for pulmonary vein isolation in cases of refractory atrial fibrillation. So, Dr. Vikram will address this issue in one of the presentations. Aortic and peripheral interventions are done in our hospital by our radiology team. We have a very good radiology team. He will be able to perform all these things without any difficulty. So we have support departments like cardiac surgery, anesthesiology, radiology, and vascular surgery. We have all the full team. So if there is anything to fall back, we can always fall back under this one. The hospital is recognized for MD medicine, DIP-NB medicine, DIP-NB cardiology, and we are clinical courses like and clinical courses for echo and cath lab technicians. Our hospital is empaneled, is an empaneled hospital for most of the insurances available in this part of the country. So the cashless system is also possible in our hospital. So I will request you to for your patients. We also perform lots of cases from CM Welfare through CM Welfare Fund. In fact, we have been doing the maximum number of CM Welfare Fund, almost 12 years in the running. So our CEO will vouch for my statement, I think. So Sri Ramakrishna Hospital, in short, in summary, provides a comprehensive and state-of-the-art healthcare to all cardiac illnesses, all under one roof. I request all of you to use these facilities for your patients and help us to improve the hospital further. Thank you very much, sir. And I personally thank our Joint Managing Trustee, our Dean, beloved Dean, Dr. Rajagopal, our CEO, Ramkumar and Aragappan for gracing this occasion and giving us an opportunity to showcase our cardiology department. Thank you, all of you. I request Dr. JKP, the senior most cardiologist of this town, to inaugurate the scientific session and conduct the scientific session on our behalf.
So we are running short of time. So I was, thanks for the honor given to me. I was the oldest cardiologist in the city. Now I have completed 44 years of cardiac service. I had many dinners with them, and I had the opportunity to take care of the cardiac part of their family for many years, till 1991, till Manohar landed in Ramakrishna. So thanks for the honor. And the most enjoyed period was in Ramakrishna Hospital. This is the only hospital where we are not dictated anything. Whatever we ask, it was given. I have been the cardiologist for almost all the hospitals in the city, all major hospitals, even smaller hospitals. But I was not given any, whatever I asked here, Ramakrishna, immediately the next day it was implemented. So my junior colleague, Dr. Chagarajan, he is enjoying this facility, and I congratulate the Ramakrishna cardiac team for bringing the most advanced the technology to Coimbatore. So, and I am really honored, and the Department of Cardiology is steadily improving, progressing, and now it stands number one. According to my rate, this is number one in Coimbatore, technology-wise, equipment-wise, care-wise, and the facility-wise. Cath labs are there. I have operated in all the cath labs. The comfort and the whatever asked is given in the present time. Recently, last week I was there. It was so comfortable, pleasure to work in there. So it's all because of the trustees who are listening to our request and making us work comfortably. So most important, we need some comfort to work with the patient, sick patients. So that's available in Ramakrishna. So thanks for all the good work you are doing at Ramakrishna Hospital. The cardiology team will, I think the cardiac surgeon is there. I must recognize the cardiac surgeon as well. I think to me, he's the number one cardiac surgeon in Coimbatore. So my first reference will be to him. For some other reasons, they may be referred for somewhere for their old contact or something. So I congratulate the team of cardiology, cardiac surgery at Ramakrishna Hospital for this wonderful work. You must continue to do this work and then maintain this standard. I'm sure you will take this hospital cardiology to greater heights. I need some more floors. I don't think the beds are available for easily now, so for medium or low class patients. So I think you will add some more beds and then add some more people are benefited from your service. Thank you. I think let's go on to the. He is the son of the soil. He has been here for I think from a teacher's family. So he was a teacher, hard worker. I honestly, I'm not telling you, I have never seen a cardiologist getting up 6:30, attending hospitals and starting the cath lab at 8 o'clock. I have not seen till my lifetime, till today. Such a hard-working person, and he has been a part of the team who made all the growth till today. I request Balaji to introduce the new facility.
He is going to introduce laser to the audience. Dr. Balaji, please.
Good evening, everybody. I welcome you all for the CME, and it's my pleasure to be here today. I thank Dr. JKP for the kind words. Now, I'm just going to briefly talk about the laser technology and where it can be used and how it is useful in our cardiology lab. Although the laser is basically light amplification by stimulated emission of radiation, and although laser has been there for several years now, initially it was not very useful because there were a lot of complications with the initial lasers available, because it used to be argon and indiag laser and it used to give continuous pulses. Now we have the newer pulse laser, where the laser is delivered in pulses and we can vary the frequency, we can vary the fluence so that we can deliver the right amount of energy to the tissue, and therefore this laser technology has come back in the last few years. Now what does laser do? With each pulse of laser, which we give at 40 to 80 pulses per second, the light is pulsed and absorbed by the tissue, and because of this the tissue gets ablated and the molecular bonds are broken, and therefore the lesion is debulked. Also, we are able to modify calcium to some degree with this laser, because it causes an acoustic pressure wave which can crack the calcium and change the vessel compliance, because it removes the heat removes the water from the cells. Therefore the cell wall is broken and the tissue can be modified. Similarly, because of the water bubbles which form, there can be we can also debulk mixed morphologies, and the materials can be broken down and lumen gain can be increased. So what has changed in the new laser? Because there are more fibers, more efficient ablation, the catheter has become more flexible, there is a hydrophilic coating now, the trackability and pushability have improved, and also we in the 0.9 mm catheter we have up to 80 pulses can be given. So, and again the newer thing what has happened is we infuse saline rather than contrast, because this helps to safely ablate the tissue with each pass. So what are the situations where this laser can be used? Some of the situations are when somebody has already had a stent and comes back with the instant restenosis. This is one setting where laser is useful. Again, there are some chronic total occlusions where sometimes we can cross with a guide wire, but because of the tight lesion, we cannot cross with a balloon. We cannot exchange it for the guide wire to a rota wire to use rotablation. Here we can use laser to drill through the tissue, and then we can perform rotablation if required and stenting. Again, long lesions, laser can be useful. Failed balloon angioplasty, moderately calcified lesions, osteal lesions, saphenous vein bypass grafts, and thrombotic lesions in acute MI. These are some scenarios where laser can be used. Also in the periphery, again for in-stent restenosis, uncrossable CTO, long lesions and thrombus, and Dr. Vikram will be talking, and Dr. Basan will be talking about lead extraction, where laser is very, very useful. Now in restenosis, what happens, how can laser be used? Basically, the normal tissues we can just dilate with a balloon, put a stent and come out. Whereas within restenotic lesions, when we dilate, the watery content from the lesion is pushed out, and therefore the lesion tends to come back inside the stent very easily. And here, as you can see, when we use laser, you can see when the laser catheter advances, as you see here, the plaque can be effectively ablated and debulked and removed, as opposed to just dilating. Again, because of this, in CTO also the treatment options are increased, which allows for better stent opposition, and we can use smaller stents if possible. So in conclusion, in CTO, calcified lesions, uncrossable by balloon, undilatable lesions, small diameter lesions, some of these will be shown by our guest speaker today, I suppose. And again, for in-stent restenosis, effective debulking can be done, and we can avoid placing an additional stent inside the in-stent restenosis. Another area where we can, this is an example of a lesion with the in-stent restenosis where laser was used, and then IVUS was used and DES was used in the native segment, and we were able to get away without another stent. Now, osteal lesions also are very technically challenging. They are fibrotic, calcified. Precise stent positioning is required, and with laser we can modify the plaque, and also we can use the laser with another wire in the side branch, which we cannot do with a rotablation. So osteal lesions can be laced again with multiple wires in place. Long lesions, moderately calcified lesions, again laser can be used. And in saphenous vein grafts, when somebody has had a bypass surgery, comes back with a graft problem in the graft, there is thrombus, there is a lesion, we can use laser, and we can reduce the distal embolization which normally happens in these degenerated saphenous vein grafts. There are two settings which when we use the laser, one is fluence and one is the repetition rate, the pulse. So fluence is like a hammer, basically the power which we use to break with the hammer, that is fluence. You can vary the fluence from 25 to 60, and again repetition you can do it from 25 to 80, and thus you can ablate the lesion. Now when we use some situations where we want to break down the lesion, normally with saline is used so that the damage to the tissue is minimal. Sometimes we can mix the saline with contrast, so that as you can see here, when the laser is used in contrast and saline, there's a lot of difference. You can see how in contrast the bubbles are formed, and it really helps to break down the lesion with a higher atmospheric pressure. Again, when we use the laser, it's better to advance very slowly so that we can get a good lumen gain. So finally, the 5 S's of laser success are selection of the lesion, selection of the sizing of the catheter, the settings which we use for fluence and rate, and using saline bolus, and some situations mixing it with contrast, and advancing the laser at slow speed. I'm sure my colleagues are going to be showing some cases, and the guest speaker is going to be showing some cases where this is useful. Thank you. This was just to introduce the technology to you. Thank you.
Respected Joint Managing Trustee, sir, respected Dean, respected chairpersons, Medical Superintendent Dr. Alagappan, and respected dignitaries. I'm going to show some cases in which complex coronary angioplasties, in which laser was very useful. In a hostile terrain, creating a path saves lives. This is, creating a bridge. It saved hundreds of lives in Wayanad landslide. And this is the same bridge. So why I am talking about Wayanad landslide in coronary angioplasty conference? Because laser does exactly the same thing. Laser creates a magnificent pathway. Wherever you just draw a line, it just creates a magnificent pathway, however hostile the coronary terrain may be. So, this is the simplest terms you can explain. ஒரு கோடு போட்டு கொடுத்தா போதும், laser will create a road, ஒரு ரோடை போட்டு தந்துரும். So, these are the scenarios where coronary laser is useful. See, we have there is a tight block, we have crossed a wire, but we are not able to cross the balloon. So, here laser is useful. And in the second scenario, the balloon is crossed, but the balloon, we are not able to dilate the balloon. Here, when we use laser, it improves the compliance by breaking the tissues and by breaking calcium also. And the favorite, substrate for laser, because when there is a something like STEMI, ST elevation MI, patient has come for primary angioplasty, there is a heavy thrombus load. In this situation, laser can save the life. If you put a balloon, it will squeeze the thrombus, it will go downstream, patient may collapse on the table. Whereas if you use laser, it will vaporize the thrombus and patient can, especially if a patient comes with left main thrombus occlusion, this can save the life of the patient. Otherwise, we may not be able to save the life. So, this is one typical situation where coronary laser is very useful. I will show you some cases where I have used laser and it has rescued the patient's life. This is case number 1, a chronic total occlusion. Chronic total occlusion is a situation which is called the last frontier in coronary intervention. Because here the block is rock solid, it is difficult to cross with wire and it is difficult to dilate the balloon also. This patient is a 76-year-old gentleman. He had diabetes, hypertension, presented with recurrent angina and he had recurrent pulmonary edema also. Angiogram showed triple vessel disease. There was CTO, chronic total occlusion in LAD, and RCA also had diffuse CTO, but he had good collaterals from left coronary artery to right coronary artery. Patient was referred for CABG many times, but he was not willing for CABG at all. So we have decided to take up the patient for LAD CTO opening. And this was the first angio shot before PTCA was started. LAD is the middle vessel and there is a gap in the middle of the vessel which is chronic total occlusion. You can see this is LAD which is shown by the top arrow and the bottom arrow shows a gap which is CTO. And now we are struggling to cross the CTO with a wire. With difficulty now we have crossed the lesion. The wire is across the lesion and now only the laser has come into play. The dot indicates tip of the catheter. Now laser atherectomy is in process. We are crossing the lesion with the laser atherectomy catheter. And after laser atherectomy is done, now we are deploying the stent. And this is the final result. See, the CTO segment was dilated with this was the first shot. This LAD is there and there is a chronic total occlusion and this is the final shot. You can see the stent which has occupied the place of chronic total occlusion. In fact, we have put 2 stents. So this patient would have otherwise, he was referred for CABG, he was not willing, otherwise patient wouldn't have survived. Now laser has rescued his life. And this is second case. This is a case of late stent thrombosis. This is a 65-year-old gentleman. He had diabetes, hypertension and morbid obesity. And he underwent PTCA and stenting to LAD at another hospital in Coimbatore. And now he is presented with acute coronary syndrome, which is due to late stent thrombosis. And I was telling about landslide and creating a channel and all. Acute MI is nothing but a thrombotic landslide inside coronary artery. This results from rupture of vulnerable plaque. In a vulnerable plaque, bleeding occurs, which closes the vessel. So this is basically a thrombotic landslide. So creating a channel of communication, that is what we do in primary PTCA, this saves the life. So here laser helps. I'll just show you the picture for want of time. This is the site of stent thrombosis. You can see the vessel, this is LAD, and the stent is in the middle. The stent got occluded because of thrombus formation, and patient presented with MI. And this is the final result after the PTCA with laser. We didn't even use a stent. Inside the stent we did lacing, meaning we used laser, and then we dilated with the drug coated balloon. That's all. We didn't put a stent also. So the stent got nicely opened up and the patency was restored. So in conclusion, laser creates a magnificent pathway wherever you just draw a line, however hostile the coronary terrain may be. This is the bottom line of laser use. So, but it is grossly underutilized. It is a mighty weapon which is grossly underutilized. So my humble request to referring doctors, kindly prime your patients, especially acute MI patients, to utilize laser, which is the gem of the tools. Because like a patient comes with acute MI and only on the table we would know the patient has heavy thrombotic load, and utilizing the laser will make the difference between life and death. So you only can prime the patients. I request you to do that. Thank you.
Good evening, one and all present here today. Thank you so much both for your presence and support. Let's proceed with further indications where we use laser. Graft interventions can be very challenging because generally these patients are elderly and they would have had bypass grafts done a few years ago, and they're generally quite notorious for thrombus formation, and anatomy can be very challenging. So let's look at a couple of cases where they've been useful. So very quickly, bypass surgery generally means you're getting another artery's help to feed the native coronary arteries where the blocks have been present. The traditionally used Lima graft, that's the left internal mammary artery, and the blue ones are those that are from the veins, the saphenous vein grafts that generally tend to give up a few years later, and they can always be quite thrombus laden, posing a bit of a challenge, especially when they come and present as acute coronary syndromes, acute myocardial infarctions. So a couple of quick cases. This is the first patient, a 55-year-old male. If you look at the number of comorbidities at age 55, this is another challenge for us in the future. He's a diabetic, he's a hypertensive, he's had a stroke in the past, and he has had bypass in 2008. He has had a native angioplasty to the circumflex in 2015, now presented with non-ST elevation MI, and has had borderline LV function. So if you look at the graft study, this is the OM graft, saphenous venous graft to OM, which is patent, and I'm not sure, I'm really sorry if you can't see the pointer, trying to do my best, if the slides can go off. This, the right coronary artery or the PDA, which is occluded, one here. And this is the Lima graft, which generally doesn't die ever, so it's always patent in most patients. So it was native triple vessel disease, occluded saphenous venous graft to the right coronary system or the PDA, and patent Lima to LAD. The challenging thing in venous grafts is thrombus most of the time. If you look at this lesion, it's quite thrombotic across its course, and rightly chosen. This is the laser in operation. So you can see this guide wire that's gone past the lesion, then the laser was deployed to vaporize the lesion, which is mostly thrombus. You can see that happening here. And eventually the check shot, you can see there's good amount of blood that's gone into the distal part of the vessel, thereby clearing most of the thrombus. Once this is done, it becomes a traditional or a routine angioplasty where you can pre-dilate, you can put in stents, post-dilate. So the conventional angioplasty gets into operation. So beyond that, then there was a stent that was deployed here, post-dilatation of the stent, and then beautiful end result that makes the right coronary patent eventually. Now the second case, or the quick hard ways, because I'm not going to touch upon how the laser works, as Dr. Balaji has mentioned, what's fluence, what's pulse repetitive rate, because the UV radiation, you have to decide on table based on the lesion. So it's important to understand the lesion as to how much fluence is needed, how much of the UV radiation you want to energize, trying to break that kind of a plaque. It's all mostly mixed plaque. Thrombus is a challenge, calcium is a challenge, and most of it is a mixed plaque. So you will have to decide on table how much of power you are going to use and how much of pulse repetitions you will have to use to make that thing work best for you. And then, as I said, traditionally you go on with the angioplasty further on. This is the second case in a 60-year-old male, bypass surgery 2004, and then subsequently had PTCAs in 2018 and 2021. Again, diabetic, hypertensive, dyslipidemic, non-ST elevation MI, very bad LAD system, hardly seen, but the circumflex was diffusely diseased. Ramus is quite all right. Again, the native right coronary artery is quite badly diseased, and then again the venous graft into the right coronary artery was badly diseased. You can see a stent here. This is a stent here. This is a stent that was done earlier in the venous graft. So a disease can again come up back in the venous graft which has already been stented, because veins are never as robust as arteries in terms of circulation, so they can come back again. And so native triple vessel disease, patent Lima graft and SVG2 RCA graft is the one that needed attention. So traditional wiring. There was a distal lesion which was again tackled like a routine angioplasty. This tight lesion here was tackled like a routine angioplasty. So there was a stent in the distal most part of the artery which opened up quite well, but this particular area was the instant restenosis that my colleagues were mentioning. So this particular area is the instant restenosis where laser had to be used for an end good result. So this again, laser was used both for two reasons: because it was an ISR, you wanted to have a good bed prepared for the stent to go in, and also because there was a bit of a thrombus. So subsequently it looks much better. So again, the hardwares used were routinely that we use for an angioplasty. So I'm not going to go into the indications again, but two important things to remember. I request doctors to understand that when we receive patients in acute myocardial infarction, there's hardly any time for a discussion like an elective case. We don't sit with the family and discuss in length about what we can see, because we don't know what we are going to encounter. But it's always important for us to largely sort of educate and create awareness regarding laser, primarily because we might over a period of time start to use laser as a technology as an ad hoc one. When we come out of the cath lab, we'll have to just tell them we had to use laser because there was a large thrombus burden. Currently, before we got laser, we would probably just open up the vessel, create some sort of a flow, then revisit the cath lab or revisit the patient again in about 48-72 hours after anticoagulating the patient to see if the thrombus burden is reduced, then do a second sitting. All that can actually be deferred. We can do a good first angioplasty with with laser and get those good results. They can also be used as an adjunct to underexpanded and underdeployed stents. So basically debulking the thrombotic lesions is what is important in venous grafts. And generally there was a note on need for distal protection devices. With laser, it doesn't seem to be a requirement, because the biggest fear is you don't want the thrombus to travel down deep into the native artery, then clog the distal most part. With laser, it seems to be very unlikely. I take this opportunity, I really want to endorse what Dr. Manoharan said. We have always had the support of the management every time we have approached them. That's how we are able to do such complex cases. And the support of the administration, CEO sir, MS, MD, everybody, whatever we have asked, we have got in terms of how we can better patient care and how we can improvise our results in the end. And also taking this opportunity to thank the team of cardiothoracic surgeons and anesthetists. We always have this, strength on the back of our mind. There's somebody one floor above us who will back us up when we do complex cases, and they've helped us in several times. And our team with the ICU, the doctors in the ICU, intensivists, and we are ever so grateful for all the backup they give us when we do complex cases. Thank you once again for this wonderful opportunity.
Thank you, Dr. Nandakumar. Which is instant restenosis, laser in instant.
Yeah, very good evening, everyone here, and I am extremely thankful to the SRH management and administration, Dr. J.K.P. sir and Department of Cardiology for giving me the opportunity to work with. And I will be presenting a case of ISR, two cases. Our case, it was a 59 years old diabetic hypertensive with old antral MI in 2021, underwent angioplasty to LAD. And this time he had presented to us with chest pain on exertion with class 2 to 3, and these symptoms he had for 4 months, and it was exacerbated by stress, emotional disturbances, and it was relieved by taking rest and sorbitrate. And general examination, systemic examination were unremarkable, and vitals were stable. And what next was our question, and routine blood investigations were unremarkable. He was having a classical chest pain, and ECG and echo, except for the previous regional wall motion abnormality which he had during the antral MI, nothing else was there. And what next is the question whether to go with the stress test or directly to go for a coronary angiogram, because the patient had a typical chest pain, 4 months. He says, sir, when I walk for 200 meters, I have to take rest and then I have to go. He roams here and there, he travels a lot, and one flight of stairs, he says that when I go to flight, if I first ramp, I have to stop and then I have to go. So with this, then we decided not to go for a treadmill test, directly to go for So this is the angiogram. What you can see over here is like the LAD. You can see the stent over here, just above the stent, and from the start of the stent, there is a tight stenosis, around 90 to 95% block. RCA was non-dominant, which was having mild disease, and similarly L6 also having disease. The culprit here is the LAD lesion, and as Balaji sir and previous speakers, Nandakumar sir was telling that ISR was the one area where the laser plays a major role, where you can see here, this is the angiogram with a tight lesion, this is the wire crossing, and after that, before went in for an angiogram, we took an OCT SAT, that is optical coherence tomography, which shows that what you can see here from below upwards, these are the stent suds. Inside the stent suds, there is a thick fibrous tissue. Here, what was the cause for the stent failure, we can easily ascertain, and here the cause of the stent failure is bit underexpanded stent, and as well as the calcification in the proximal part of the stent, and here there is a neointimal hyperplasia. The neointimal hyperplasia is the one where when we use the routine balloons, like it gets slip, it either goes down or up. In that case, we have to use a cutting balloon. So far, before the advent of, before the laser comes, we have been using either cutting balloon or other modalities to handle this. But with the help of the laser, what you can do is, like in the previous pictures, what sir has shown, that you can see the ablation of laser ablation, the tissue gets ablated. Here, this is the tightest lesion segment, thick fibrous cap and neointimal hyperplasia, and this is the nodular calcium at the 11 o'clock to 1 o'clock position. These are the problems when we do an angioplasty, the stent will not get opposed properly. In that area, the stent thrombosis can form, the malapposition can come, and the patient may present in the future with the restenosis or stent thrombosis. So this is the laser ablation. You can see that the laser catheter 1.4 mm ELCA catheter was used. It was going from above downwards, and after taking the laser, this was the laser. We have had a recent workshop. The technical person from Delhi has flown, and he was giving us insights in the lab, and this was the laser console as we have seen in the earlier pictures, and this is the pre-laser and post-laser angiogram. You can see that this is the pre-laser angiogram. There is a tight lesion. After the laser, you can see there is improvement in the stenotic part, and after that, we did a pre-dilatation, routine angioplasty, and you can see this is pre-laser. It was 1.2 millimeter square at the tightest segment. After post-laser, you can see we could have some gain of lumen because this area, the tissue gets ablated. As we have seen in the previous pictures, in the angiography pictures, the catheter was going in and coming out. Here you can see with the help of intravascular imaging, what we call it as OCT, and you can see that the tissue gets ablated. There is some shaving of the calcium occurs with the help of this laser catheter. And this is then routine angioplasty, the stent deployment and post dilatation. Once again, the post stent. See, this was before stent, what it was like. After the laser, you can see that there is a good apposition and there is a good gain of lumen. This is what with the help of laser we can achieve. So you can have good outcomes, no major adverse cardiovascular effects in the future. You can predict that with the presence of calcium, presence of malopposition, presence of edge dissection or tissue prolapse in the edges, we can ascertain those things with the help of the intravascular imaging and give a good, better results to the patients. And this is the final results. You can see that there was a tight lesion here before, and it has become a TIMI3 flow with good result. So this was before, and this is after. Yeah, sorry. And another short case, the another case is a 66 years female with diabetic hypertension, has underwent PTCA in 2009, where Dr. J.K. Pisar has done this angioplasty in 2009, and then again in 2015, he had RCA and infraval MI. For that 2015, he underwent another stent, and in 2023, he presented with symptoms of effort angina. For that, because of insurance purposes, he has not presented to us. He went to a nearby hospital where the proximal stent was good, and again here in the mid part of the segment another stent was put, and because of significant calcium down, the balloon was not crossed. Then they could not do the procedure with the good result, so they did an attempted PCA, and then once again she came back to us, and then what we did was like with the help of laser, we did a angioplasty for the patient, and you can see that there is a because of the calcium, we were not able to push the balloon down. It was uncrossable lesion, where we have used the guide liner to deliver the laser catheter. In the first picture, you can see that this is the guide liner. This is the routine guide. Inside that guide, there is another guide. This is the guide liner. Through that, we took a laser catheter which has ablated the tissue below and the calcium below, and you can see the balloon inflated down, and this was the stent deployment, and this is the final result. So, yeah, this is the final result. And see, it was what was before like here, it has become like this. Now the patient is doing well for last 6 to 7 months, and she is better without any symptoms. And thank you one and all again, and thanks for the opportunity for me to present this case. Thank you.
Two wonderful cases. We will keep the discussion at the end. Now we will move away from this laser and talk about this cryoablation. How to extract leads. Suppose if you are stuck with the leads inside the ventricle, how to remove them with the help of laser. Dr. Vikram Vignesh, who is part of the Ramakrishna family, he will present the lecture.
Good evening, one and all. I thank our management for this opportunity. So I'll be sharing our development of electrophysiology unit in Ramakrishna, and I'll share one of the cases of atrial fibrillation ablation that we did with the help of a cryo balloon. So before 3 years, we restarted our electrophysiology unit under the Department of Cardiology. So we installed the advanced 3D navigation system, which are used to localize the arrhythmia focus in the heart. So we were able to offer services right from the ablation of supraventricular tachycardia and some of its varieties like WPW syndrome. And then we moved to ablation of ventricular tachycardia, that is VT. And presently we are able to offer the ablation treatment for atrial fibrillation in the form of cryotherapy. So we initiated with radio frequency ablation. By this we mean we will go percutaneously into the chambers of the heart and we will localize the arrhythmia focus. So once we localize the arrhythmia focus, we will deliver radio frequency energy. Radio frequency energy is a kind of a heat energy which we use to ablate the abnormal heart tissue. So we have done radio frequency ablation in atria, and also we have done radio frequency ablation for the ventricular tachycardia. So these forms the curative procedures for these arrhythmias. So this is one of our earlier cases. So she is a staff nurse who works in our emergency, and she had a VT in emergency. This, you can see the wide complex ventricular tachycardia, which was suggestive of VT. So she was taken up for the electrophysiological procedure. We localized her ventricular tachycardia to be originating from the right ventricular outflow tract. So this is what I was talking about, advanced 3D navigation system, where you can create a model of the heart using the catheter and in real time without use of any radiation. So we will be able to localize the VT focus, and we gave radio frequency energy, and then we cured her of ventricular tachycardia. She is doing well and she is still working with us in our emergency. So that is what it is. So that was a form of a heat energy, that is radio frequency ablation. We have also installed the cryoablation. Ours is the first center to have an intracardiac echo guided facilitated cryoablation in Coimbatore. So this is especially used for treatment of atrial arrhythmia, that is atrial fibrillation. We all know that atrial fibrillation is the most common sustained arrhythmia, and it is one of the leading cause of the stroke worldwide. So how does this atrial fibrillation occurs in any individual? Commonly, the sinus node works in everyone whomever is in sinus rhythm. When patient is having atrial fibrillation, the trigger for atrial fibrillation usually comes from the 4 pulmonary veins which are connected to the left atrium. So what we do exactly here is we take the cryoballoon. Cryoballoon is a form of a cold energy, and we do an interatrial septal puncture. Then we cross into the left atrium and we occlude all 4 pulmonary veins sequentially, and we ablate the abnormal tissue. Why this is advantageous is it is minimally invasive, that is non-surgical, short hospitalization time, reduced recurrence of arrhythmia, and also there is an improvement of patient's life. So what we do in this is we take a special balloon, and through this balloon we circulate the coolant, that is liquid nitrogen gas, through a special chamber. Once this goes into the balloon gets the balloon's temperature drops. When the temperature drops, there is a formation of an ice crystal, and as the ice crystal forms intracellular region, the abnormal cells around the pulmonary vein undergoes necrosis so that the arrhythmia doesn't occur. So I'll show you a short animation clip. So this is the cryo balloon. So we would like to go from the right atrium. So we cross into the left atrium and we place this kind of a circular catheter in the pulmonary vein. So after we place the circular catheter, we take this balloon. So once we inflate the balloon, this occludes the ostium of the pulmonary veins. After that, we send the coolant. So once we pass this coolant gas, what happens is the area around the pulmonary veins get so this is our index case. So she is a 67-year-old female. She is a hypertensive. She had recurrent episodes of paroxysmal atrial fibrillation. Many times she had come to the emergency. We used to give Cordron and control. Oral therapy we started on Cordron, but she was not tolerant to the drug. Then we switched over to other drugs such as flecainide, beta blockers. She was on multitude of drugs, but none of these antiarrhythmics were giving any symptom relief to her. She also had recurrent AF related heart failure admissions also. Her ejection fraction was 60, her left atrial size was 4. So we planned to do a cryoablation in this elderly female. So we took a CT anatomy of the pulmonary veins to look at any abnormality anatomically. There was none. So we proceeded with the cryoablation. So the advantage of using an intracardiac echocardiography that we have is you can puncture the interatrial septum with a pinpoint accuracy, and it greatly reduces the risk of any complications that are associated with interatrial septal puncture. So this is the where there is a kind of a tenting, and here there is the needle is situated. So once it tents, the needle just passes into the left atrium from the right atrium. So what we do next is we take this kind of the circular catheter, and we place this circular catheter in each pulmonary vein sequentially. So once we place this circular catheter, then we take the cryoballoon. So what you see here as a whitish rounded structure is the pulmonary vein occluded by the cryoballoon. So we are confirming the circumferential occlusion of this pulmonary vein by injection of the contrast. What the contrast is filling is nothing but the pulmonary vein which is getting drained, which is draining the blood from the lung into the left atrium. So once we confirm that, then the liquefied coolant is passed, thereby ablating the abnormal tissue. So as I said, we will go into each pulmonary vein to left and to right, superior and inferior respectively. So once we ablate, we would like to confirm the success of our ablation. So what we create is, again, this is called as electroanatomical mapping. So this we create without use of any fluoroscopy, just with our catheters, where the position of the catheters and the impedance that is produced by the catheters are measured by this 3D navigational system, and this kind of an anatomy is created. So you can note, so the arrhythmia is, it goes on, and after sometimes the arrhythmia gets terminated once all 4 veins are isolated. And also we have, with the help of the laser in our EP department, we have established the laser lead extraction system. Compared to the conventional tools, cutting tools, which we use to extract the infected pacemaker leads, these laser offer tremendous advantage of less morbidity to the patient. So that is it about our electrophysiology work under our Department of Cardiology. I thank our management for this opportunity. Thank you one and all.
That was a great speech to hear in this great time. Thank you, sir. In this inaugural CME, each and every delegate is special. To add upon gallants who came a long way to make the CME even more special. Dr. Anuj Basan hails from Chandigarh. He has completed his MBBS from JJ Hospital, Mumbai in 1993. He did his MD Internal Medicine at LTMC Medical College, Sion. His quest for clinical expertise led him to many top centers of the world and did his fellowship in interventional cardiology. He has more than 22 years of experience in cardiology and has performed more than 1,25,000 cardiac procedures. In the year 2008, he performed the first radial angioplasty in Western Maharashtra in Nashik. He had set up instrumental catheterization labs in Jabalpur, Maligwan, Dhulia and Jalgaon, and has done more than 15,000 free of cost angiography, angioplasty and bypass surgery for the economically underprivileged patients. Dr. Anuj Basan possesses strong clinical, leadership and communication skills with a commitment to academics. I am privileged to welcome our special guest speaker, Dr. Anuj Basan, Director, Department of Cardiology, Icon Hospital, Dombivli, Mumbai, to give us few words on role of laser in complex coronary interventions.
Good evening, everyone. It was great to see such a good cardiac department, and I can tell you this is the most well-equipped department in the country. Actually, if we just read this department, I don't think in Mumbai also we don't have this cryoablation laser with optical and this OCT, IVUS and everything in one center. There is not even a single center in Mumbai. So this is a really appreciable. Actually, all the efforts put by the cardiology department and our trustee in this, how they have always tend to encourage this staff and bringing the new technologies. It's not easy. They are all expensive, and sometimes patients are not affordable for that. But even then, creating such a high standards, it's really appreciable, sir. Thank you, thank you. That's a great. I'll start with the first of the case. Actually, this is a pacemaker lead removal. This was an 87-year-old female patient, and this patient had a PPM inserted in 2014. Then came with a pacemaker pocket infection. So I thought that better to remove the lead. Actually, I won't go into much of the details. Actually, the video is there. We can play in the last part of the video of this. So most important step here is we have to separate the lead, and we have to just fix the inner coil. Actually, if we just lose this step in first of our case, we lost that inner coil, and after that we were not able to remove the lead. So that inner coil separation, that's the most important step, and after that putting a lead fixing device, then we can easily remove this. It was unimaginable. It was my first case, and I never thought that it was so easy with the laser. Looking at the mechanical, it just walks through. I can tell you that only some technical aspects you have to know, that you have to keep it co-aligned and axial along this. So that is this is the most important step actually. And even if we have a problem with this, then we can always use snare from this femoral side to take this. And most important here is to keep our surgical OT ready and keep a balloon occlusion so that the SVC tear that doesn't happen. So, and another important step is to keep the edge of the bevel tip towards this shorter side toward the SVC, so that it doesn't hurt this. So initially the catheter was not going inside, so I was thinking that I think this time also we are going to fail, like the last time where we were not able to push our lead holding the fixation device inside. But the Philips guys and this laser team, they were there with us. They said, you just on the laser. And I can tell you, the moment we started lasing it, it was just like nothing. It started moving. So I was thinking that we should not be very fast. So there are some of the steps actually here. Whenever we have across the subclavian and SVC junction, we should go slow. The fluency rate and everything, that should be decreased at that time so that it doesn't damages the SVC. So very slow advancement. And full procedure video I have, actually we can play after this once this is finished. So this is a very slow advancement across the SVC RA junction, and then across the tricuspid valve, slow advancement. Here we have to take care because a lot of VPCs and VT that might happen actually, that we have to go very careful. Slow advancement, we can stop in between, give a breathing time to that, and then again start our procedure. And this is only a single lead. The main role of this comes when we are extracting many leads actually, like in a dual chamber pacemaker or a CRT infected patient. There it becomes very tough. So there the role of laser is the most important in this. This is after the removal of this across the tricuspid wall, and this we can see the fibrin sheath across this. We did a insertion from the other side. So this is a single chamber. In a dual chamber pacemaker, then it becomes this, like if we want to upgrade it to the AICD, we have to remove the other lead sometime. I have one patient who had put a permanent pacemaker, then later realized it's a ERVD after 2 years of VT. Then we had to put another lead. So at that time it was very difficult. So the procedure was made successful only because of the laser at that time. Very good. This is as mentioned earlier, where we use a laser with a rotor ablation. This was a 67-year-old female. So I thought there's a calcified lesion, full calcium is there from in this. So I thought it will be easy to pass our wire, and then we can get a rotor, and then we can do the procedure in this patient. Patient already had a calcium nodule in this, so that was planned later on. So when I started the procedure, I always use 8 French guide while using these procedures actually. I was not able to deliver my smallest balloon, Ikaguchi, also at that time. So at that time, after multiple so 2 to 3 balloons, we were not able to cross. Then I thought better to switch on to the laser. Let's see what it will do. So when we started the lasing, after that, I was able to deliver my microcatheter down there, and successfully delivered the rotawire. And then after 1.25 Rotapro, that was able to do the rotablation and deploy 2 stents in this patient. This was the final result after deploying 2. So rotablation would have been unsuccessful because of this. You were not able to deliver this. So what it changes the compliance of the vessel wall to make a delivery of all the balloons and our devices very easily. So this is the advantage of the laser. So we cannot depend only on the one technique when we are doing all these tough cases and all. We have to have all our devices with us so that at any time we can use those devices. This is a distal left main bifurcation, culottes, that was a distal left, osteal lesions. So after doing a ELCA both sides, deployed culottes, and this was the final. This is a laser is a game changer in acute MI. I can tell you so many patients of acute MI when we see all these patients with the acute interval MI, RBBB presentation, huge thrombus load, and when we start doing our procedure at the end of the day, invariably we see these patients landing up in a no reflow state, and after that multiple inotropes, intra-aortic balloon pump, even then the LV function that doesn't recover that much. But if you straight away go with the laser in all these cases, you will definitely see a change. It is totally changes your mindset. I never imagined that laser can work in such a this. So I can think first frontier of a laser is a thrombus, which is a off-label indication according to Phillips, but this is the most important indication, I think. The 42-year young male, huge RCA. I'll show you another case where I have not used a laser. Here I used a laser directly in this patient. What difference it could make actually laser. So after passing this, doing a laser, and then the final result. No need of putting a stent and directly coming out. Huge RCA, only small embolization in the PD. Otherwise, because they didn't go into the PD branch as such. So this was the final result without doing, only with the laser. This patient later on diagnosed with a hyperhomocystinemia. That was the reason for this. It's a chronic total occlusion. There's a long segment occlusion. So crossed it with a Gaia 2, and then there is a failure of the passage of the balloon. So I had to use a laser in this. Laser just walks through, I can tell you, it just walks through in a chronic total occlusion. It's so easy to do the case with the laser. Sometimes you feel why you were struggling so much. So that thought actually comes into play when you are doing all these cases. Using 3-4 balloons, then just deep diving your guiding and all other things. So this was the final result. Instant restenosis is, after the ablation you won't see any tissue only. That is the beauty of this. Initial indication, that is your stent is not expanded, then you use a laser. But I think nowadays I'm using laser in all my ISR directly, because the tissue gets ablated. After that it is very easy for you to just do some scoring balloon and do a DEB and just leave it like that. This is a 2-3 time intervention I had done. Now again came with this. So long 230 balloon, then the laser catheter, IVUS. And stenting mid to distal LAD and DB to proximal and the mid LAD. And putting left main to LAD stenting. That was a significant lesion on IVUS in this. And this is a result of this, final. Did a check shoot of this patient actually a few days back. So everything is fine. This case I think I done 2 years back. This is a very interesting case. This is a mother of a dentist. She came with the inferior wall MI, cardiogenic shock, systolic BP 70, lot of inotropes, and this bedside IBP was inserted in other hospital. Nowadays I send, whenever I get a call for a bad patient, we send our people, they put a IBP there only, then only the patient is transferred. Because many of the times when these patients are transferred, they die during this transport only. So we have changed that scenario in our place, Kalyan Dombivli. We send the patient, people there only. They put a bedside IBP and then transfer the patient. So it becomes safer. Most of the patient they are able to reach if you put a IBP there at the spot. Wait for 1 or 2 hours, let her stabilize, put a neckline and everything, give inotropes and this, and then we just shift the patient in our ambulance. Specially designed our ambulance like that, shifting all these bad patients. So this patient was transferred like this, bradycardia and this. So this was a very bad calcified vessel of the left side, dense calcification and a super dominant RCA. Huge thrombus we can see, huge. Dense calcification. in this patient. So everyone was thinking that what I'm going to do actually. So in this patient, I thought I'll directly go with the ELCA. In this, calcium is also there, and this calcium ELCA will work in a moderate calcium, not in a very severe calcium. So after this it was not passing. This catheter was not going through that. So at that time, took a guide extension device. And my advice for this ELCA for all this thing is that most of the time we should be using this guide extension device. The stability is very good with that. And even after 2-hour dilatation, I was not able to extend my guiding into distal. So after that, I used a 3O scoring balloon, and then I just advanced my device in the distal after that. And then delivered the ELCA catheter here and did the after the ELCA, it's a very common in all this setting to see such type of picture. We should not be disheartened with this. Okay, what has happened? I don't know that it is messed up or whatever it is. Because initially when it used to happen, then I always used to get something wrong has been done. You can just wait, do a gentle ballooning, and that gentle ballooning I did it with a 3O. There's a huge vessel, distal PD, that 3O claw, and after that you'll see such a result. In most of the cases you'll see, even in the graft also, sometimes you can see a no reflow, but again the flow will resume up once you just, because it breaks into so many these particles. So sometimes these things, they can happen actually. So this is after deploying 2 stents, and this is the final. Huge RCA. So AM minor resistant thrombus, this is another 35-year-old patient. This also we had to put a IBP in the other hospital, QRBBB, interval MI, ostial occluded, totally 100. So I thought here patient was not affording, let us do a multiple run of thromboaspiration. But after the thromboaspiration also, nothing was just, it was just a slight improvement after this doing a thrombosection. All thrombus was still there actually. So I thought now better to use this after ELCA. After the ELCA, that was before that, and after the ELCA, this was the picture. And stenting from left main to LAD, this. Most important is it doesn't causes distal embolization, what previously has also been mentioned. It doesn't cause distal embolization, so that translates into the long-term benefit. Patient LV function doesn't decreases. You can see a very good myocardial blush grade. That's the advantage of this. This is another patient with the left main thrombus. 6 to 7 years back, I had lost 2-3 patients like this while doing an intervention with such type of thrombus. Because what to do in such type of thrombus? Patient with the anterior wall MI, intermittently ST elevation used to happen, then again it used to subside down. So here I thought directly do an ELCA here. But the catheter size was 0.9. I did not use a 2.1 or 1.4 catheter because of the cost restraint. But even with this also, there was a resolution of the thrombus inside this. So next, what to do actually, leaving this thrombus. So next was I used a penumbra along with that. With penumbra, in first run only, I got this. Out of this. So the thrombus with the ELCA got resolved, and this was the left, and that I could suck it out with the penumbra and came out without doing this. Did an IVUS run. There was no stenosis as such, and left it like that only. So after 3 weeks, again did a CT angio. It was perfectly fine. So this patient, this is another patient, left main LAD ISR with this. Very tight lesion, we're not able to cross it with this wire.
Thank you, Dr. Basin, for a wonderful lecture. Are there any questions from the audience addressed to?
Pulmonary embolism anytime.
Which one?
Pulmonary embolism.
Never. We have angiojet. Angiojet we have used in pulmonary embolism, but with the pacemaker, because I can tell you 80% of the patient, they will have a cardiac arrest and bradycardia with the angiojet. But best device for that is a lightning device by penumbra. Lightning device is much better because the amount of blood it sucks, penumbra, normal penumbra, the 12 sheath is huge. patient hemoglobin from 10 it becomes 6. So the lightning device what they have introduced now, it cost is it's expensive, 8.5 lakh plus 1.5, nearly 10 lakh the device cost, but same console you can use, and it only sucks the thrombus, not the blood. That device is a game changer in such patients actually. All of them are reusable. It is how you maintain these devices actually, that is what it is. Penumbra with the normal, this penumbra I am using not with their catheter, that catheter along with that console, or a capturer. Capturer is a device, very smooth by eye vascular, same what they have this. You can just go very distal along with that. Means even you can enter into the PL, PD or this, you will never feel actually, such a good device it is. Because like a thrombuster and all other devices you try to push, you feel resistance, sometimes gritty feeling is there, but not in that device.
So not for second use unless it's maintained.
Which one? Penumbra?
Not Penumbra, the other thrombus aspiration devices.
Most of them you can use many times.
Yeah. How well it's maintained, how well it's sort of...
You don't require that much of this. You only require a Coronary star. Coronary star is one of this thing which you have to maintain. That is just 17,000. You purchase 4 or 5 and the rest you can do. Because patient benefit is huge with this. Means our benefit also, because the first run only when you just suck out the thrombus, half of the job is done.
Yes, for that pulmonary embolism, was it called angiojet? I think it came up...
No, angiojet. It was this angiojet.
5-6 years ago, right?
Yeah, angiojet machine I am having actually, angiojet machine also.
You have that.
I have angiojet machine, but use so many devices are coming every day. With this penumbra now, angiojet use. But in DVT sometimes you require both of these devices. Because angiojet, you can just dissolve your thrombus, which you cannot do with the penumbra.
Because I think it was present, it was about 5-6 years ago, and I think we didn't...
You can use a local thrombolysis. The spray rate is very good actually. It sprays this. So that device is also good, but you have to combine all these devices. That is what it is. The technology you have to combine and then do this.
Anuj, yeah. Anuj, one comment.
Yes, sir.
Very good work and wonderful results. Only one comment about the vaccine.
Yes, sir.
I had the vaccine 3 doses officially, 1 extra dose unofficially. I did not have any problem. I am not on any drugs till today for cardiac problem. So don't relate that vaccination to the incident that happened to one of your relative. I don't think
no,
it's
my
related to,
my
because
relative.
from vaccination center to your place, vaccination gun, it will work at least 2-3 days to work. So I did not relish that your comment on the vaccination. From the vaccination center to your cath lab. That's not due to vaccination, maybe pre-existing disease.
Those thrombus actually, those type of only thrombus. We don't see anything else. You don't see even on the OCT any dissections also, any unstable plaques also, nothing as such. So not relating to it, I don't know, that is a questionable whatever it is, but that happened from March to June, it happened like that only, February, March till June. After June the incident decreased. Those
Thank you
3-4
very
months.
much, Dr. Basin, for your wonderful lecture, and we were very much enlightened by your beautiful cases and excellent results, basically. As a cardiologist, these are phenomenal. So we will come to the end of the session. Our CEO will address the...
Thank you. Thank you.
Honoring is considered to be one of the most respectful practices we follow as a tradition. As part of the event, to felicitate the honors, respectively, I am glad and privileged to welcome our Chief Executive Officer, SNR Sons Charitable Trust, Shri C.V. Ramkumar Sir, on stage, please.
It is great enthusiasm that I welcome you all to our continuous medical education program of Sri Ramakrishna Hospital by highlighting our shared commitment to excellence, compassion, and innovation in healthcare. I am filled with immense gratitude for the participation and support of distinguished medical professionals present here today. First and foremost, I extend my deepest thanks to our esteemed Joint Managing Trustee, Sri R. Sundar Sir. Your strategic insights and unwavering support have been invaluable in the growth of our hospital. Thank you very much, sir. I also express my heartfelt gratitude to our most respected J.K. Periswamy sir and Dr. Anju Bashin of Icon Hospital, Mumbai, for having taken their time to come to this CME program as a guest speaker. Thank you very much, sir. Thank you, sir. A special acknowledgement goes to our Medical Director, Dr. Rajagopal sir, and Medical Superintendent, Dr. Aragapan. Your leadership and dedication ensure that we maintain the highest standards of medical care. Continuous education is the cornerstone of medical advancement in our rapidly evolving field. Staying together with the latest developments, techniques and technologies is not just beneficial, it is imperative. This program stands as a treatment and testament to our commitment to fostering an environment of lifelong learning and professional growth. I would like to extend my heartfelt gratitude to the organizers of the CMA program, Department of Cardiology, Sri Ramakrishna Hospital, for their meticulous planning and effort in putting together this comprehensive program. Your dedication to enhancing our medical community's knowledge base is truly commendable. Thank you very much, all doctors of Ramakrishna Hospital. Your dedication to continuous learning and professional development is what drives the excellence in patient care that Sri Ramakrishna Hospital is known for. Your commitment to improving your skills and exploring your knowledge ensures that we continue to provide the highest standards of healthcare to our patients. To our esteemed speakers and facilitators, thank you for sharing your expertise and insights with us. Your contributions are invaluable, and your willingness to share your time and knowledge significantly elevates the quality of this program. To our participants, I sincerely thank everyone for taking part in this program. In conclusion, let us make the most of this opportunity to learn, to engage, and to grow together. Let us embrace the new ideas and innovations that will be discussed and work towards integrating them in our practice. By doing so, we reaffirm our collective commitment to advancing medical science and enhancing the patient care. Thank you for all being with us here today and for your unwavering dedication to excellence in healthcare. I wish you all an enlightening and inspiring experience during this CME program. Thank you very much. Thank you for the opportunity.
That was the sparkle speech for the felicitation. Thank you, sir. No duty is more urgent than that of returning thanks. Tonight, we had an opportunity to hear all your valuable words and share knowledge with us. Following the salutation, to express the heartfelt gratitude to all the delegates who made this event possible and great, I would like to welcome our Medical Superintendent, Sri Ramakrishna Hospital, Dr. Alagapan sir, for the sincere vote of thanks.
Good evening, everyone. It is with great pleasure and gratitude that I extend our heartfelt thanks to all those who have made today's CME program on laser coronary angioplasty a resounding success. Firstly, a special thanks to our esteemed Joint Managing Trustee, Thiru Sundar sir, for your unwavering support and commitment to our institution. Your leadership and vision are instrumental in guiding us towards greater heights. We are deeply grateful to our distinguished guest speaker, Dr. Anuj Bashin from Icon Hospital, Mumbai. And Dr. Bashin, your insightful presentation and invaluable expertise have enriched our understanding of laser coronary angioplasty. We appreciate the time and effort you took to share your knowledge with us. A warm thanks also goes to our chairpersons, Dr. J.K. Periswamy and Dr. S. Manokaran. Sir, your guidance and presence continue to inspire us and elevate the standards of cardiology within our institutions. Our sincere thanks to our CEO, Sri Ramkumar sir, and Dr. Rajagopal sir, our medical director. Your leadership and support play a crucial role in fostering and thriving environment for medical education and excellence. We would also like to extend our gratitude to all of the senior cardiologists and cardiothoracic surgeons attached to Ramakrishna Hospital. Your participation and contribution to today's program are greatly valued. A special thanks to Mr. Magesh Kumar for his exceptional efforts in organizing this event. I thank all the referral doctors, special invitees, SRH consultants, and their family members. Your presence and engagement have added immense value to today's discussions and interactions. We are also grateful to Philips and Viva Scientific Limited for their support, which have played a significant role in the success of this event. Finally, I thank the marketing, PRM, and IT teams. Your behind-the-scenes work ensured that everything went off without a hitch, and your efforts are deeply appreciated. As we conclude, let us take with us the insights and knowledge gained today and continue to strive for excellence in our field. Thank you once again for a valuable contribution and for making the CME program a memorable and successful occasion. Have a great evening.
Thank you, sir, for the perfect conclusion with your simple words.